So generally speaking, the larger the operation, the bigger the risk of adhesions. There were quite a few people who also put answer D, which was diverticular disease. So diverticular disease, we'll touch on it later, but it mainly presents with left-sided abdominal pain, whereas here there are some features of obstruction. So the abdomen is distended, you're hearing the tympanic sounds, and the patient is vomiting, which would suggest that there is a blockage. And next slide. And again, so here we have two abdo films taken from Radiopedia. So the abdominal film on the left is a barn door picture of a small bowel obstruction. So this X-ray came from a patient who'd presented with a distended abdomen and vomiting. In the X-ray, you can see the multiple dilated gas-filled loops of small bowel. And the reason that these X-ray appearances are very typical for small bowel obstruction is because you can see the dilated small bowel, which is in the center of the abdomen, and the large bowel at the periphery is collapsed. The abdominal X-ray on the right is that of a patient who'd presented with a distal large bowel obstruction. So they presented with absolute constipation for 24 hours. And again, this is a very typical abdominal film for a patient with a large bowel obstruction. And you can see the differences between the X-ray on the left and the right. Next slide. And again, so when you're assessing a patient and you're worried about small bowel obstruction, it's really important to take a really good history. You also need to consider whether this is complete bowel obstruction or partial, where some stool is still able to pass, or where the patient may still be able to pass some flatus. So they'll give a history of abdominal pain with distension. Now, the abdominal pain itself is usually colicky at the beginning, which then it becomes a continuous pain. The patient will feel quite bloated and they'll be vomiting, and it's often bilious vomit. And if there's complete obstruction, they will not be able to pass any flatus or stool. We touched a bit on this briefly, but it's really important to take a really good history from this patient and assess whether they've had any previous abdominal or gynecological surgeries, or if they've ever had a hernia or a hernia repair. Simple bowel obstruction may be managed conservatively. However, complicated small bowel obstruction or that with ischemia will require urgent surgery. If untreated, small bowel obstruction can lead to ischemia or necrosis of the bowel, as well as perforation. Next slide. So we've touched on this a wee bit, but when you're examining the patient, you want to see if there's any scars that could be indicative of previous abdominal surgery. When you're listening for bowel sounds, they're often high-pitched and tympanic, and they're often described as they sound like you're in a submarine underwater. In complete obstruction, there may be a completely empty rectum on PR exam. And if there's any necrosis or ischemia of the bowel, your patient will have a peritonitic abdomen. And next slide. So this is just a picture taken from theatre. And on the right here, you can see the ischemic bowel, and it's all dark and mottled. So like we said earlier, if small bowel obstruction is left untreated, you can get ischemia of the bowel, which can then progress to necrosis of the bowel, which may even perforate. And next slide. So when you're thinking about the causes of small bowel obstruction, you can divide it into three categories. So there's factors outside of the bowel, factors relating to the bowel wall itself, or factors relating to inside the bowel. Adhesions are the most common cause of small bowel obstruction in the Western world, of which previous intra-abdominal operations are the main risk factor for developing adhesions. An intra-abdominal hernia may become incarcerated, which would cause an acute obstruction or may cause an acute obstruction. And when we're looking at factors relating to the bowel wall itself, obstruction is the most common complication arising from Crohn's disease and occurs as a result of tissue swelling and formation of scar tissue. An appendicitis may cause small bowel obstruction if there's a loss of periappendicular inflammation or any formation of adhesions. And in terms of factors relating to inside the bowel, malignancy, foreign body ingestion, or gallstone ileus may cause obstruction. Gallstone ileus is fairly rare, but essentially it occurs when a gallstone passes through a fistula between the gallbladder and the small bowel before becoming impacted at the ileocecal valve. And next slide. So when you're working a patient up, there's a variety of different investigations you should order. So the first, which is particularly relevant if you're an FI1 or an FI2, is you want to get a really good set of bloods. So you want to look for, you want to get a full blood count, U's, LFTs, CRP, lactate, and amylase. And for any patient who may go to theatre, you should check your hospital policy guidelines, but they will almost definitely need a group and save, if not a cross match. In terms of your full blood count, they might have an elevated white cell count. You want to look for any electrolyte derangement, given that electrolyte derangement is fairly common in patients presenting with bowel obstruction. And when you're looking at a lactate, it may be falsely low. So even if your lactate is within normal limits, this does not exclude a bowel obstruction. It's really important to get an erect chest x-ray in these patients, and that's because you're looking for evidence of any free air under the diaphragm, which would indicate a perforation. Your CT abdo-pelvis is the most commonly used investigation for diagnosing patients with bowel obstruction. Not only will it confirm your diagnosis, but it can also tell you why the bowel has become obstructed. So are there any adhesions? Is there an incarcerated hernia, or is there a tumour? A small bowel contrast study using gastrographin isn't as commonly used, but can be very useful. There's also some evidence to suggest that gastrographin can also help to relieve some cases of small bowel obstructions caused by adhesions. And this is because gastrographin is a water-soluble and fairly dense material. And next question. So your initial management would involve an A to E approach, and this is pertinent if your patient is really unwell. You want to insert an NG tube in to decompress the bowel, and you also want to start IV fluids and make this patient nil by mouth. So that's where your common phrase drip and suck comes from. Patients often have electrolyte derangement. Specifically, you want to watch out for the potassium and sodium, and if there's any derangement, you need to correct this, especially before theatre. You also want an accurate fluid balance. You want to know exactly how much fluid is going into your patient and how much they're passing. And the patient will need to discuss with the surgical team for consideration of a surgical intervention. And next slide again. So large bowel obstruction is a surgical emergency. So we focused on small bowel obstruction, and now we'll move on to large bowel obstruction. Next slide. Presentation can be fairly similar in some respects. So patients will have abdominal pain, which is often cramping in nature. They'll feel bloated and their abdomen will be distended, and they'll be constipated of wind and feces. Nausea and vomiting is often a later sign compared to small bowel obstruction, simply because the obstruction is more distal. Next slide. So causes of large bowel obstruction would include tumours, so either colonic tumours or external tumours compressing the bowel wall. So for example, ovarian cancers, stomach cancers, and so forth. Strictures can cause large bowel obstruction, as can volvulus, hernias, or adhesions. And next slide. So your supportive care for patients with large bowel obstruction would include analgesia, IV fluids, and antiemetics. For those who have a large bowel obstruction because of sigmoid volvulus, you can decompress the sigmoid volvulus using flexible sigmoidoscopy. For patients with other causes of large bowel obstruction, you'd want to consider a surgical intervention. For patients who are not fit enough for a surgical intervention, you can consider palliative stenting just to relieve that blockage. It is important to note that the majority of patients, around 70% of patients with large bowel obstruction, will require surgical intervention, and that can be either laparoscopic or open surgery. This often involves either primary anastomosis or stoma formation. Okay, and I think now we're on to the next question. So I'll give you a minute to read this question and to answer. Okay, so now we'll move on to the next slide, which has the answer. So the correct answer for this question is a left hemicolectomy plus post-operative chemotherapy. So left hemicolectomy is the preferred surgical option for tumours involving the distal transverse colon or descending colon. The reason that this patient needs post-operative chemotherapy is because they have a JIC-C cancer, so there's lymph node involvement, and there's a lot of evidence to suggest that these patients do better with chemotherapy. The other answer, which lots of people put, was a left-sided hemicolectomy plus post-operative radiotherapy. The reason that this answer isn't correct is because radiotherapy is not commonly used in colon cancer. It is, however, used in rectal cancer, so that could be an option for patients presenting with rectal cancer. But in colon cancer, if you imagine the colon being a poorly defined target, and there's also quite a few dose-limiting structures surrounding the colon. So for example, the small bowel, the liver, kidney. So radiotherapy isn't as appropriate in these patients. Okay, and next question, next slide. And again, so colon cancer is common. It's actually the third most common cancer cancer in the UK for both men and women. There are risk factors associated with developing colon cancer, so increasing age, hereditary syndromes like familial adenomatous polyposis, HNPCC or Lynch syndrome, juvenile polyposis or Peutz-Jeghers. It's also associated with smoking or an increased alcohol intake, as it is with processed meat, obesity and previous exposure to radiation, or those with inflammatory bowel disease like ulcerative colitis. Weaker risk factors would include lack of dietary fibre, limited physical activity, asbestos exposure, and red meat. And next slide. So we touched a little bit about this in the previous question, but this is one of your classification systems that you should definitely know for your medical school exams. So the JICS classification is very widely used. So JICS A is a cancer that's limited to the bowel wall. B is one that extends through the bowel wall. C is where there's regional lymph node involvement, and D is when there are distant metastasis. Next slide. TNM staging or TNM classification is a more recent classification which provides a more uniform classification of colorectal cancer. And essentially what the last question touched on is patients with a JICS stage C or a stage 3 colon cancer are likely to benefit from adjuvant chemotherapy, and so this should be considered in this patient cohort. Next slide. So investigations for colon cancer. A QFIT is often requested by a GP, however, it's not often requested in hospital. If you have a patient with a suspected colon cancer, you want to book them in for a colonoscopy. Now, the benefits of colonoscopy are you can visualize the cancer if there is one, and you can also take a tissue sample, so a biopsy, to confirm it. Once you have histological confirmation that you have a cancer, you then want to do a CT chest, abdo-pelvis for staging, so you want to look for evidence of distant spread. For patients who can't tolerate a colonoscopy because it's quite an uncomfortable procedure, you could consider CT colonoscopy or CT colonography. However, it's not as useful as as a colonoscopy itself. In rectal disease, you can request a pelvic MRI or endorectal ultrasound just for more information. CEA is not a diagnostic tool, but it can be used to monitor therapeutic response to interventions. And next slide. So here's a wee bit about the conditions which may predispose you to developing colorectal cancer. So familial adenomatous polyposis is caused by a mutation in the APC gene, and approximately 80% of cases are inherited in an autosomal dominant pattern. These patients typically develop over 100 colonic adenomas, and patients at risk are offered an annual flexible sigmoidoscopy from age 15. And essentially, if polyps are identified on scope, then they'll typically be offered resectional surgery. If polyps are left untreated, there's almost a 100% cancer risk. FAP is also associated with duodenal cancer. Gardner syndrome is a variant of FAP in which patients may also develop epidermal cysts, supernumerary teeth, osteomas, and thyroid tumours. HNPCC, or Lynch syndrome, is caused by germline mutations of DNA mismatch repair genes, and it carries around a 30 to 70% risk of colorectal cancer. It's also associated with gastric cancer, endometrial cancer, breast and prostate cancer. Colonic tumours tend to be right-sided tumours and mucinous. These patients are offered colonoscopy every 1 to 2 years from age 25 and are often offered prophylactic surgery. Peutz-Jeghers in most cases is caused by mutations on chromosome 19. Patients develop multiple benign intestinal hamartomas, which may cause episodic obstruction and intussusception. There's an increased risk of colorectal cancer and gastric cancer, as well as breast, ovarian, cervical, pancreatic, and testicular cancers. Annual examination and complete intestinal endoscopy is recommended every 2 to 3 years. Okay, and now we're on to the next question. So I'll give you about a minute to read this. Perfect. And shall we see the answers? Excellent. So most people got the correct answer for this, which was anterior resection with a temporary loop ileostomy. So this patient has presented with an ileostomy. It's in the right iliac fossa and there's liquid contents and it's spouted to protect the skin from irritant small bowel contents. The two ends of the bowel implies that this is a loop ileostomy. Anterior resection is the preferred surgical management for rectal tumours that are more than 8 centimetres from the anal margin. An anterior resection involves removal of the disease segment with formation of a primary anastomosis between the proximal colon and distal rectum. You can often use a temporary loop ileostomy in these patients to allow the distal anastomosis to heal. So that's why that's the correct answer. The other answer that people had selected was answer B, which was an AP resection with a temporary loop ileostomy. So in an abdominal perineal resection, they take away the rectum as well, and you would be left with an end colostomy rather than a loop ileostomy. So that's why that answer isn't correct. So next slide. So when you're comparing an ileostomy and a colostomy, generally speaking, your ileostomy is sited in the right iliac fossa. It will have fairly liquidy green contents and it's quite spouted. And the reason for this is because the material coming from your ileostomy is really quite irritant to the skin. So by creating a spouted ileostomy, it minimizes the risk of this contents coming in contact with the skin. A colostomy, by comparison, tends to be sited in the left iliac fossa as more solid contents, and it isn't as spouted. These are your answers that you need for your exams, but in real life, there is some variability, and that is purely based on where the surgeon can bring the colon out or the small bowel out most easily. But generally speaking, ileostomies are in the right iliac fossa and colostomies are in the left iliac fossa. So next slide. So this is just a brief diagram highlighting the different operations that may be performed. So a right hemicolectomy is used for right-sided tumours, so those at the cecum, the ascending colon, or the hepatic flexure. A left hemicolectomy is used for tumours of the splenic flexure, descending colon, and proximal sigmoid colon, although a sigmoid colectomy can be used for tumours of the sigmoid colon. A Hartmann's procedure is essentially a sigmoid colectomy, where the proximal end of the colon is brought out to form a temporary end colostomy, and the distal bowel is oversewn as a rectal stump. A Hartmann's procedure is usually used in emergency. So, for example, bowel obstruction, ischemia, or toxic megacolon or perforation. A subtotal colectomy removes most of the large bowel but leaves the rectum, whereas a panproctocolectomy removes the entire large colon and the rectum. This is often carried out as an elective procedure in ulcerative colitis in patients that haven't responded to medical therapy. For patients who undergo a panproctocolectomy, they'll end up with a permanent stoma. An AP resection is used for tumours less than 8 centimetres from the anal margin. And anterior resection is used for tumours more than 8 centimetres from the anal margin. Okay, and now on to our next question. And I'll give you about a minute to read through this. Okay, and we'll move on to the answers now. Excellent. So almost everybody got this question correct, and the answer was contrast enema shows multiple outpouchings at the sigmoid colon. So this is a very barn door presentation of diverticulitis. So the patient has left-sided abdominal pain, and they've also got a history of constipation, and they're sort of middle-aged to older. So next slide. There. So it's quite important to understand the differences between diverticular disease, diverticular, and diverticulitis. So diverticular disease simply describes the clinical condition resulting from the presence of diverticula. Diverticular are outpouchings of the mucosa and submucosa, and they typically affect the sigmoid colon. Diverticulitis is when you have inflammation of these diverticula. So diverticular disease, if your patient is symptomatic, they'll present with left-sided abdominal pain. They may experience some rectal bleeding, and physical examination may be normal, or they may be quite tender in the left lower quadrant. Diverticulitis is when they present with pain, fever, and nausea and vomiting. On physical examination, they're usually sore in the left lower quadrant, and there may be guarding. If there's diffuse abdominal tenderness in patients with diverticulitis, it's suggestive that there may be a perforation. So next slide. So this diagram shows exactly what a diverticulum is, and essentially it is just an outpouching of the bowel wall. And how we explain this to patients is we call it wear and tear of the bowel. When we talk about management of diverticular disease, which is on the next slide. So patients who have diverticulosis and they're completely asymptomatic, you don't need to do anything with these patients. If they are symptomatic of their diverticular disease, so if they have pain, if they have intermittent rectal bleeding, you can encourage them to increase their dietary fibre intake, to stay hydrated, and to take painkillers as and when they need. For patients with diverticulitis, they may be managed with oral antibiotics. However, if there's no improvement with oral antibiotics, this might warrant admission to hospital for IV antibiotics. For acute rectal bleeding, these patients may require transfusion. However, if they're hemodynamically unstable, you'd need to manage them in an A to E approach. For patients with multiple admissions to hospital for IV antibiotics, you could consider surgery for these patients. And next slide. So we've touched on this a little bit, but essentially you can manage these patients conservatively if they're coping well and they don't have a fever and there's no signs of diverticulitis. However, if there are signs of diverticulitis, so they have a fever, they have a raised inflammatory markers like a raised white cell count or CRP, then you'd want to be thinking about oral, if not IV antibiotics and IV fluids and other supportive measures. If, for example, a diverticular were to become so inflamed that it ruptured and caused an abscess or caused fecal peritonitis, these patients are likely to need some sort of surgical intervention. So for those with an abscess, this can be drained either radiologically or surgically. And for those with perforation, you need to be thinking if this patient needs surgery. Okay, and next question. So again, we'll give you about a minute to answer this. Okay, and why don't we see the answers? Okay, and the next slide. Excellent. So again, the majority of people got this question correct. So the correct answer is a surgical embolectomy. So this patient is presented with acute limb ischemia, most likely secondary to an embolus. So if you notice from the history that they have a past medical history of an irregular pulse, which is suggestive that the patient has AF and is more likely to develop an embolus. A leg that's been affected by embolus requires immediate surgical revascularization with an embolectomy. A surgical bypass would have been the correct answer had the patient presented with acute limb ischemia on a background of long-standing atherosclerotic disease rather than AF. IV heparin is an important step in the management of acute limb ischemia as it prevents distal propagation of the thrombus. However, it's not a definitive management option, and this patient needs urgent surgery because there's complete limb ischemia. IV streptokinase, so IV thrombolysis, is an option in incomplete limb ischemia. However, in complete limb ischemia, where all 6 Ps are present, thrombolysis isn't really an option because to dissolve the thrombus would take several hours. And again, fasciotomy isn't correct because that's the management for a patient presenting with compartment syndrome, which isn't in keeping with this presentation. So we'll move on to the next slide. So acute leg ischemia is severe symptomatic hyperperfusion of a limb that develops acutely, so definitely within 2 weeks. Next slide. It's really important to remember the 6 Ps on the next slide. Perfect. So the limb will be pulseless, it'll be painful, it'll be really pale. There's essentially paralysis because it's too painful to move, paresthesia, and it'll be perishingly cold. Patients with acute limb ischemia secondary to thrombosis describe a slightly longer history of symptoms and often have features of peripheral vascular disease in the contralateral limb. Acute limb ischemia secondary to an embolus has a much more acute onset and is often precipitated by AF. And so the next slide. So we touched a wee bit on the causes. So thrombosis is a cause of acute limb ischemia and it's often in those with atherosclerotic disease. An embolism may cause acute limb ischemia, so patients with AF. Vasospasm could cause acute limb ischemia and you might see this in Raynaud's phenomenon. Or similarly, external vascular compromise, so for example, trauma or compartment syndrome could cause acute limb ischemia. And next slide. So you need to manage these patients with an AT approach. You want to give these patients oxygen, you want to give them IV fluids and analgesia. It's important to remember that this is going to be a really painful event for the patient, so you want to keep them as comfortable as you can. It's really important to do a full set of bloods, so full blood count using these LFTs, CRP, and a lactate. A VBG is also a very quick way of getting a lactate on the wards. And if there is any concern that this patient is going to go to theatre, you need to get a valid group and save, if not cross-match. You'll need to get an ECG for this patient if you're considering taking them to theatre, and you need to discuss this patient with the vascular team. Whilst you're working any patient up for theatre, it's important to keep them nil by mouth. And next slide. So in a patient with a thrombotic cause of limb ischemia, if there is incomplete ischemia, you can use angiography to plan your intervention. This isn't appropriate in complete limb ischemia because they need urgent bypass surgery. And if you were to perform angiography or thrombolysis, it's essentially going to delay your definitive management. If a patient has an embolic cause of their acute limb ischemia, you need to take them for immediate embolectomy. And the next slide. Excellent. So we'll give you about a minute to answer this question. Okay. And next slide and answers. Excellent. So the answers for this question were quite mixed, but there were a lot of you who got the correct answer, which was straight tract with the internal opening anterior to the transverse anal line at the 2 o'clock position. So if you move on to the next question, the next slide. This is a really good diagram which essentially explains the answer for the last question. So essentially any fistula with an external opening anterior to the transverse anal line will drain in a straight line. Any fistula with an external opening posterior to the transverse anal line will drain in a curved tract to drain at the 6 o'clock position. You can work out the exact position where your tract is draining if you PR your patient. The only other important thing to note is, although anterior fistula drain in straight tracts, if your anterior fistula has an opening that is more than 3 centimeters away from the rectum, it will actually drain in a curved tract, as would a posterior. Okay, and the next question. And again, we'll give you about a minute to answer this. Okay, and we'll move on to the next slide with answers. Excellent. And again, the majority of people got this question right. So the correct answer was referral for an open mesh repair. So this patient has presented with a direct inguinal hernia. They are less likely to strangulate than an indirect inguinal hernia, but they should be repaired if they're large or symptomatic, and this patient is coming with an uncomfortable inguinal hernia. For uncomplicated unilateral hernias, so where there's no incarceration or strangulation or necrosis of the hernia, and in low-risk surgical candidates, an open mesh repair has a lower rate of recurrence than non-mesh repairs. Laparoscopic mesh repair is the management option of choice for recurrent or bilateral hernias, and laparoscopic repair results in faster post-op recovery and better cosmesis compared to non-laparoscopic repair. Referral for an open non-mesh repair is the management of choice for patients with an irreducible or strangular hernia, or where the bowel is obstructed. A mesh repair should be avoided in these patients because there's a higher risk of infection. When the patient is more stable, mesh repair is preferred as there is a lower risk of recurrence of the hernia. Truss support belt with a surgical referral, if no improvement, is the management of choice for patients with a very high surgical risk and a low life expectancy. Patients with larger symptomatic inguinal hernias should be managed surgically where possible. And watchful waiting is the management of choice for small asymptomatic inguinal hernias. However, again, this patient has a large hernia which is causing symptoms, so a surgical referral is appropriate. And we'll move on to the next slide. So generally speaking, indirect inguinal hernias tend to occur in younger males and occur as a result of a patent processus vaginalis. These hernias occur through the deep ring and often descend into the scrotum, and there's a higher risk of strangulation. Direct hernias, by comparison, tend to occur in more elderly males. They're acquired. They rarely descend into the scrotum and occur because they pass through a defect in the posterior wall. They have a much lower risk of strangulation. Generally speaking, it's important to note that inguinal hernia will occur superior and medial to the pubic tubercle. When you're examining a patient, following reduction of the hernia, pressure of the deep ring prevents the reappearance of an indirect, but not a direct inguinal hernia. And this is because an indirect hernia enters the femoral canal at the deep inguinal ring. However, a direct hernia emerges from a defect in the posterior wall medial to this point. Okay, and next question. Excellent, and again, we'll give you a minute to answer this. Okay, I will move on to the next slide and answers. Excellent. So the majority of people got this question right as well. So the most important thing out of all these tests that you need to look at is the calcium of 1.95. And the reason for this is explained on the next slide. And then the one after. So when you have a patient who's presented with pancreatitis, where possible, it's really important to try and calculate the modified Glasgow Emery criteria score. So essentially, you can remember this score using the mnemonic pancreas. And essentially, a score of 3 or more indicates that your patient is going to have, or will likely have, more severe pancreatitis, and would probably be better managed in IT or HD for quite intensive monitoring and aggressive resuscitation where need be. The indicators themselves are based on the degree of potential complications arising from pancreatitis, such as necrosis of surrounding tissue, reduced hormone output, so for example, reduced insulin output, and respiratory distress syndrome. And we'll move on to the next slide. So the most common causes of pancreatitis can be remembered using the mnemonic get smashed, and this is really important for your finals when you can't think of the answer that you need. So gallstones is the most common cause of pancreatitis worldwide. However, in Europe, ethanol is the most common cause. When you start work as a foundation doctor, it's not uncommon to see some patients who represent with pancreatitis relating to alcohol. Other causes include trauma, steroids, mumps, autoimmune diseases, scorpion bites, hypocalcemia, hypertriglyceridemia, hypertension, ERCP, and drugs. ERCP is also quite an important one to comment on, because if you ever have a general surgery job, there will be a huge number of your patients who go for ERCP. It's important to consent them for the risk of pancreatitis and also to monitor them for especially the first 1 to 2 days after the ERCP to make sure they're not developing any epigastric pain or any other signs of pancreatitis. And so remembering all the different drug causes of pancreatitis, this is covered in the next slide. So you can remember it using the mnemonic fact sheet. So furosemide, azathioprine, thiazides, tetracyclines, statins, sulfonamides, sodium valproate, hydrochlorothiazide, estrogens, ethanol, protease inhibitors, and NRTIs. Out of all these, you will often see patients on furosemide and statins and thiazides. So those are ones to sort of keep in the back of your mind. And moving on to the next slide. So patients with pancreatitis present with really sharp epigastric pain, often radiating through to their back. They are very sore to palpate, and they often clutch their stomach, and they'll be writhing on their bed if it's really quite severe. They often vomit quite a lot, and they often give a history of a recent alcoholic binge or a history of gallstones. With any patients who you're working up for pancreatitis, it's also really important to elicit exactly what drugs they're taking and if there's any new medication changes. In terms of abdominal examination, they're going to be sore, they may have some guarding, and they shouldn't be grossly peritonitic. There are some signs that are quite rare, but they are your textbook signs. So in hemorrhagic pancreatitis, you may see Gray-Turner's sign or Cullen's sign. So Gray-Turner's sign is when you have bruising along the flanks, and this indicates retroperitoneal bleeding. And Cullen's sign is bruising around the periumbilical area, which is again highly associated with pancreatitis. And we have an example of Gray-Turner's sign on the next slide. There we are. And again, on to the next slide. So when you're investigating a patient with suspected pancreatitis, it's really important to get a set of bloods. So in those, you want to include your calcium, your glucose. For centres that offer it, you should try to request a lipase in addition to your amylase. So an amylase, 3 times the upper limit, is diagnostic for pancreatitis. However, the degree of elevation of amylase is not related to the severity of disease. For any patients presenting with epigastric pain, it's really important that you perform an erect chest X-ray and an ECG. The reason for getting an erect chest X-ray is to exclude any free air under the diaphragm, so any perforation which could present with epigastric pain. And the reason for getting an ECG is because patients who present with MIs who have atypical presentations may also present with epigastric pain. So you just always need to get a chest X-ray and an ECG in patients with epigastric pain. Other imaging, you could do a CT abdo-pelvis in patients with severe pancreatitis approximately 72 hours after presentation. And next slide. So patients with pancreatitis often require quite aggressive fluid resuscitation, and a fluid balance chart goes hand in hand with that. So you need to know exactly how much fluid your patient is receiving and how much they're passing. These patients are often really sore and they need really good going analgesia to make sure they're comfortable. And they likely need antiemetics. So when you're fluid resuscitating with crystalloids, you want to try and keep the urine output at greater than 30 mils an hour. You often start with a litre bolus and use that to try and maintain adequate urine output. And the usual amount or fluid requirements is about 3 to 5 mils per kilogram per hour. To enable you to monitor fluid balance more accurately, you should be catheterizing these patients and asking for hourly urine volumes. IV antibiotics aren't usually indicated because they aren't thought to improve the outcomes. Unless necrotizing pancreatitis is present, then that's usually at the discretion of the surgeon looking after them. Insulin may also be given in the presence of hyperglycemia due to the damaged pancreas and not being able to produce or release as much insulin. Calcium may be given if hypocalcemia is present, but it's not actually prescribed prophylactically. There we are, and we're on to our next question now. And again, we'll give you about a minute to answer this. Okay, and we'll move on to the next slide and answers. Okay, so the correct answer for this was B. So refer for supervised exercise program, clopidogrel 75 milligrams once a day, and atorvastatin 80 milligrams. And what I'll do is I'll try to explain why this is the right answer. So we know that this patient is presented with clinical features consistent with chronic leg ischemia. These patients need to be considered for 2 hours supervised exercise per week for 12 weeks, approximately 3 months. Cardiovascular risks should be managed with smoking cessation, weight management, high-dose statin therapy, antiplatelet therapy with clopidogrel, and management of blood pressure and diabetes. So according to NICE guidelines, clopidogrel has replaced aspirin as the antiplatelet of choice in the secondary prevention of cardiovascular disease. And that's because it has a better side effect risk profile. If your patient can't tolerate clopidogrel, that's when you consider aspirin in this patient cohort. Atorvastatin 20 milligrams is used in the primary prevention of cardiovascular disease. However, in patients with established peripheral vascular disease, they should be given 80 milligrams of atorvastatin. Okay, and on to the next slide. So risk factors for chronic limb ischemia include smoking, diabetes, hypertension, hyperlipidemia, physical inactivity, and obesity. And essentially in chronic leg ischemia, they have peripheral arterial disease, which occurs because there's significant narrowing of the arteries. The most common cause of this is atherosclerosis. So the next slide touches a wee bit on symptoms. So these patients will often present with pain when they're walking that's relieved by rest. They often have pain in their buttocks and thighs, again, which is relieved at rest. They'll often have a pale, cold limb with hair loss, and they may have ulcers which don't get better. Similarly, they may have poorly healing wounds and weak or absent pulses. And next slide. So you want to do a baseline cardiovascular risk assessment. You want to get a blood pressure, full blood count, blood glucose, lipids, and ECG. You also want to take a really good history and clarify if they're a smoker, how often they exercise, and what their diet's like. And your basic investigation is your ABPI. So ABPI cutoffs are discussed in the next slide. So an ABPI of greater than 1.2 indicates abnormal thickening of vascular walls, and you want to think, has this patient got diabetes if you're getting an ABPI reading of greater than 1.2. Essentially, a normal ABPI in a diabetic patient cannot exclude peripheral vascular disease, and there almost certainly need further investigation. An ABPI 0.9 to 1.2 is normal, 0.8 to 0.9 indicates mild disease, 0.5 to 0.8 indicates moderate disease, and less than 0.5 indicates severe disease. And we'll move on to the next slide. So when you're investigating patients with chronic limb ischemia, you want to get a Doppler. So a Doppler is a very quick, non-invasive, cheap test, and a Doppler allows you to assess blood flow through that limb. An MR arteriogram is used for patients who are candidates for revascularization, and a CT arteriogram is used for patients who are unsuitable for an MRI, so for example, patients with metalwork. Digital subtraction angiography is usually performed at the time of intervention or for monitoring disease. It's important to remember that when you're getting your Doppler, it's really useful for determining the site, the severity, and the length of stenosis. You also want to counsel the patient on managing their cardiovascular risks. So next slide. So again, you want to get them started on antiplatelet therapy, so clopidogrel, 75 milligrams once a day. You can give them aspirin if they don't tolerate clopidogrel. You want to give them a lipid-lowering therapy, so for example, atorvastatin, 80 milligrams once at night. In diabetic patients, you want to optimize their glycemic control, and you need to manage high blood pressure appropriately and make sure that's within target range. And again, you want to counsel patients where possible to stop smoking. Next slide. These patients are often quite sore, and if they're sore, they're not going to be able to exercise as much. So it's really important to manage their pain appropriately where possible. So you want to use the analgesia ladder and start with simple analgesia and then work up. Okay, and next slide. So for patients with intermittent claudication who've trialed risk factor modification and exercise and haven't had any improvement in their symptoms, you want to refer these patients for either endovascular or surgical revascularization. Similarly, when there's critical limb ischemia, so where there's rest pain, tissue loss, and ankle artery pressure of less than 50 patients, these patients should be referred urgently to the vascular MDT for endovascular or surgical revascularization. Endovascular methods are particularly for small, discrete stenosis. Bypass is recommended for larger areas or more extensive stenosis. If the critical limb ischemia is unsuitable for other interventions, or if the patient isn't fit enough to undergo either endovascular or surgical capacity, you may need to consider amputation. And next question. So this is a really common question in medical school exams. So we'll give you a minute to answer this. Okay, and next slide and answers. Excellent. So again, the majority of people got this question right. And if we move on to the next slide, I'll just explain a wee bit about why that's correct. So in this diagram, you can see here that the cystic artery is branching off from the right hepatic artery. So this is a really common question in exams. The other important anatomy to identify and tease out from the picture is to be able to identify the celiac trunk. So the celiac trunk supplies the foregut, and it arises at the level of T12. There's three main branches that you need to know about. It's the left gastric, common hepatic, and splenic arteries. So if you're not quizzed about the cystic artery, you'll probably get at least one question about the celiac trunk. Okay, and now we're on to our next question. And again, we'll give you about a minute to read and answer this. Okay, and we'll move on to next slide and answers. Excellent. So it looks like the majority of people got this question correct again. So this patient has presented with a history that's highly suggestive of esophageal adenocarcinoma, and he has histology to support that as well. So obesity is a significant risk factor for the development of esophageal adenocarcinoma. The other risk factors tend to be more associated with esophageal squamous carcinoma. Okay, and we'll move on to discuss a little bit about esophageal cancer. So squamous cell carcinoma of the esophagus is the most common esophageal cancer worldwide, and it tends to affect the top 2/3 of the esophagus. Smoking and high alcohol intake are your really important risk factors, but others would include achalasia, increased intake of hot beverages, and increased dietary nitrosamines. So nitrosamines are found in processed foods. So for example, processed red meats, alcoholic beverages, and things like cigarette smoke as well. By comparison, esophageal adenocarcinoma, which is on the next slide, tends to affect the lower third of esophagus. So whereas esophageal squamous cell cancer is the most common cancer worldwide, esophageal adenocarcinoma is the leading cause of esophageal cancer in the Western world. It's really strongly associated with obesity and gastric or gastroesophageal reflux disease, so GORD. And again, smoking is a key risk factor for these patients. So essentially, patients who have recurrent reflux, this leads to metaplastic formation of the mucin-producing glandular tissue, also known as Barrett's esophagus. And ongoing reflux will lead to more changes of these cells. For patients with Barrett's esophagus, this has an annual rate of conversion to esophageal adenocarcinoma of about 0.5% per year. And the reason that this is now the leading cause of esophageal cancer in the Western world is because of the increased rates of metabolic syndrome within our populations. However, like we said before, squamous cell cancer is the leading cause worldwide. So I believe we've reached the end of our questions